Another minute or two. Good afternoon, everybody. Welcome to an EFCA talk, and thank you for joining us this evening. I'm delighted this afternoon. We have a hectic schedule to get through and a good panel. Just for those that have not been with us before, if you leave your comments, I will feed them to the panel as we go through this evening. So this evening, we are delighted to be joined by Professor Kerry Novak, who's a Clinical Associate Professor of Medicine at the University of Calgary and Deputy Division Head. Her clinical practice focuses on IBD, and she developed the first clinic in North America to use bedside intestinal ultrasound, which we will refer to as IUS, to objectively evaluate the bowel. We will also then be joined by three panelists who will join us after Dr. Novak's presentation. We will have Vaso, who is the president of the Greek Association and the EFCA Youth Group coordinator. We will have Isabella Grosso, who's the president of the Romanian Association and also an EFCA delegate. And we will have Roberto Salda, who is the EFCA coordinator of innovation and patient engagement. So as I said, if you want to have any comments, I will feed them to the panel and Professor Novak as we progress. So we would also, on behalf of EFCA, we would like to thank AbbVie and Pfizer for supporting the talk. And again, hopefully we'll have a very interactive talk. So I welcome Professor Novak.
Thank you.
Good afternoon. I'm going to leave you now, Professor Novak, over to you to inform us all. Thank you.
Wonderful, wonderful. Thank you so much for having me and welcome. Good evening, everybody. It's only 10 o'clock here in Alberta, where I am in the west coast of Canada. I feel incredibly privileged to be speaking to an esteemed European audience from Chile, Canada. So welcome this evening. I'm going to maybe bring up my slides. So I'm excited to talk to you all today about a growing global innovation in the care of inflammatory bowel disease, which is the use of intestinal ultrasound. Many of you have access to this in your clinic. It's routinely used in lots of different large countries in Western Europe, like Germany and Italy, and other countries it's growing, like in Denmark, Sweden, among others. So we're going to go through the nuts and bolts of why this is an important test that might replace endoscopy in lots of circumstances. So many of you are familiar with ultrasound. So we use ultrasound because it's so safe. And so this is a beautiful baby growing in a mum. And ultrasound has been used since the early to mid 1900s. So this technology has been used for more than 50 years. But what's interesting is we have tended not to use it for looking at the bowel. So today what I'd like to do is talk a little bit about how we understand inflammatory bowel disease and what our goals in caring for you and your disease and how we develop those goals together. Then we're going to talk a little bit about ultrasound as a novel approach to using, to evaluating the bowel and as a treatment target. And then we'll talk about a little bit about the future and how we think ultrasound will change care. So when we think about, this is a beautiful highway in Alberta. We're looking at the Rocky Mountains right beside British Columbia that are the border between Alberta and British Columbia and Calgary. And this is just really the road forward upon diagnosis of inflammatory bowel disease, how you and your provider map out what those goals look like for care. And so when we think about goals of care, we have structured that based on expert consensus. You may or may not have heard of the STRIDE guidelines, but essentially what we try to do is we think about different aspects of you as a whole person so that we can improve your health and your quality of life. And so the first and foremost target is how you feel. So symptoms really are very important. So your symptoms might be diarrhea, abdominal pain, sleeping through the night, fatigue, all of the things that create a complex way in which we experience our gut. And so this is really the first goal of treatment, is to make sure that you have symptom control. There are some challenges around symptoms, though, even though it is of primary importance and probably one of the most important factors that contribute to your quality of life. The challenge with just controlling symptoms is symptoms are very complex and they don't always correlate with objective disease activity. So you can have inflammation in the bowel that's quite aggressive and not have any symptoms. And vice versa is also true, where you can have lots of symptoms, diarrhea, abdominal pain, and no objective evidence of inflammation. And that's because the manifestation of symptoms in our gut is so complex. It's different in different diseases. Crohn's disease can be very silent yet progressive, whereas ulcerative colitis, usually if you have diarrhea, frequency, and bleeding, that reflects objective disease activity. All of this is important, and it's important that we focus on improving your symptoms, but it can't be the only treatment goal, because that does not affect outcome nearly as much as we would like. And we know that from large studies. You may have heard about the CALM study, but basically in many, many different centers, they looked at monitoring patients with symptoms versus monitoring patients with biomarkers, specifically fecal calprotectin, so an objective measure of disease activity. And the patients who had their therapy guided by fecal calprotectin did better. They went to the hospital less, they went to the emergency less, and they had fewer surgeries. So we know that symptoms and controlling symptoms are not enough. So then we use biomarkers. Biomarkers are basically stool tests of inflammation or blood tests of inflammation. And we also aim to make sure that these are normal, all of which I'm sure is not unfamiliar to you. One of the most important goals of therapy is to heal your bowel. So these two images, you might be sleeping when you've had a colonoscopy in the past, but the image on the left, that is the end of the right colon. You can see this tiny opening here is the appendiceal opening orifice, and this circle here is the ileocecal valve that attaches to the small bowel. And then the image on the right is a beautiful image of healed terminal ileum. And this is what we attempt to achieve with medicine to try to get the bowel to heal. But remember, this is only looking at the bowel from the inside. So this view from the inside, although very important, inflammatory bowel disease is a systemic condition. So it affects more than just the inner lining. Crohn's disease, for example, affects all the layers and the mesentery. Ulcerative colitis affects the submucosa, the mucosa, so the inner layers of the bowel, and also outside of that, and the mesentery. So when you imagine this lens, you can imagine how you change the lens or look at an individual affects how we understand the disease, and then how we understand those treatment goals that I just outlined for you. So if you think about imaging, this is a great way of thinking about, if you look at just from the outside or just from the inside, you miss the complexity and the depth of the structure. So with this beautiful donut, you can imagine you wouldn't see any of the donut itself if you were just on the inside and only saw the jam, and you wouldn't see the sugary coat. And same as with the coffee. So you get this very broad perspective when you look at structures in cross section. And that's what imaging gives us. And each way in which we look at you adds value and is important. Historically, the way we have done imaging is on the left-hand side, you have a CT scan, and you can see down here in the right lower quadrant, thickened terminal ileum. And this is a beautiful high-resolution study, a CT scan, but it has radiation. And therefore, we can't repeat that for you on a regular basis because it can increase the risk of some malignancies. So we don't use CT scans to monitor you on a regular basis. We tend to use it in more acute circumstances when you're sick and unwell and potentially in the emergency department. And even then, we try to minimize it so we don't irradiate you. The panel on the left is an MR, a magnetic resonance enterography, and you can see the little line where the black ring is. That's thickened terminal ileum with lots of inflammatory mesentery around it. And this is a test that we do that has no radiation. It has intravenous contrast. So there are some risks, although rare, associated with that. But in many places, there are a couple of issues with MR. One is, for sure, in Canada, we have long waits to access MR. It's an expensive study, and we don't have really good access in Canada. And I suspect in lots of parts of Europe, it might be similar. So we have to wait a long time to get access to MR. And the second thing is it's not easy for you to experience it. I don't know how many of you that are listening tonight have ever had an MR, but you have to lie very still after drinking almost a liter of negative contrast, which is often cholite, which makes you poop. You've got to lie in the scanner anywhere between 30 and 45 minutes. And the more still you are, the better the image is. So they really get you to do lots of breath holds and lie on your back for a very long time. And it's hard for patients. It's hard for everyone. So it's not a hugely desirable test. But this is how historically most countries in the world have used cross-sectional imaging to evaluate your bowel. So what about ultrasound? Isn't it difficult to use ultrasound of the bowel because the bowel has air in it? Well, that's kind of this historic myth that is really being disputed now. This is an example of a patient with a very short segment Crohn's stricture in the jejunum, so in the small bowel. So I hope you can see with my pointer, and please do add comments into the chat. We'll have a great discussion after I show you these slides. If you have questions, I welcome them. The circle at the bottom of the image is the kidney, so it's not bowel at all. But this big circle here is dilated small bowel behind the stricture. So this straight thickened segment here is a short segment stricture in the small bowel. And when I show people videos of this, you can see swirling contents in this obstructed small bowel segment of Crohn's disease. So we can see amazing images of your bowel using ultrasound, and we can look at the entire bowel with no prep in clinic that is very well tolerated. So that's the main reason why we're here, is to help you understand why ultrasound is really taking a huge leap forward across the globe to try to better evaluate your bowel accurately and in a timely fashion when you're having follow-up with your IBD specialist. So when we think of introducing different tests into clinical care, there's a number of characteristics that we must consider in order to make changes to care. And, you know, doctors are very conservative. We tend to need a lot of evidence and a lot of data to make changes. So change and innovation takes time. But I will tell you, ultrasound is taking the world by storm because there's so much common sense evidence that this is a fantastic way to look at your bowel. So the test characteristics that we like to demonstrate so that we introduce a technology like this to your clinical care includes we must establish that it's an accurate measure of disease activity. So we can't use something that, has an accuracy that is low. So we know when we look at accuracy that it very much reflects disease activity, and we'll talk about that in detail. We have to understand whether it's acceptable to you, whether it's repeatable in clinic. So if you can't tolerate the test, then it's unlikely that we will be able to implement it. We need to make sure that actually, if we want to implement it because you like the test and it's accurate, that it's available to you. You have to access that test in order to use it. Pardon me. And then finally, it can't cost the earth. It has to be a cost-effective tool that doesn't cost the health system or you a lot of money. And ultrasound hits all 4 of these key parameters. So let's start with accuracy. We know based on a number of studies that symptoms are a bit variable, but it correlates well with ultrasound, as well as fecal calprotectin. There are large studies showing that fecal calprotectin correlates very well with ultrasound, and most importantly, to endoscopy and to other cross-sectional imaging modalities, which are our most important and accurate measure of disease activity. So here's an example you can see of the sigmoid colon. This is a patient who provided me with consent to show you their images. Here you've got these large white stripes. Those are deep ulcers in the sigmoid colon. Pardon me. And then a correlate image in the sigmoid where you have thickened bowel that is lighting up with color Doppler because it's inflamed with blood flow, increased blood flow. Same thing with cross-sectional imaging. So the image on the left, on our left, you can see this is terminal ileum with lots and lots of blood flow. Here you've got the color Doppler signals right in the wall, and you can see this white wall. Inside the wall is just stool and air. So this kind of rounded structure with this thickening here, that's the increased wall thickness, which is characteristic of Crohn's disease in this segment of bowel. And then we see the same thing on MR. So the same thickness with this black thickened wall coming in the small bowel that's feeding into the cecum, it correlates very, very well with disease activity on ultrasound and MR and CT. What about patient preference? Well, what do we mean by preference? Is it a well-tolerated test? Do you need to drink a ton of fluid? Do you have to prep? Do you have to do a colon cleanse? Can you eat beforehand? Can you fit it into your schedule? There are many, many elements I don't have to explain to you about what makes a test tolerable and then preferred. When we look at data and interview information from patients, there are a number of factors that, of course, you consider when you think about a test, and many accept a number of risks when the test is highly accurate, like an ileocolonoscopy. But what is very important is that no matter how acceptable intermittent colonoscopy is, it's a difficult test for you to do the prep, to have the sedation, to take the time off of work or school, to get rides back and forth. It's challenging. So it limits the repeatability. So we can't use it as a frequent treatment target measure. So some of the factors that you tell us that play into your evaluation of whether a test is acceptable would be whether or not you can repeat it in clinic because you can tolerate it, whether there is preparation, whether you feel pain with the test, and then your whole experience. One of the wonderful things about ultrasound when I scan patients is that I can teach you what I'm seeing and help you understand where the disease is, how severe the disease is the bowel moving properly, because we can see real-time motility on the ultrasound, and then what we're going to do about it and why, so that you can see directly what is going to impact you and then engage and be a partner in the decision-making. What about access and availability? This is a big challenge, and we can talk about it more in the panel discussion because this is a global effort to increase access. What you need to access The tool is trained providers. You need a machine in the clinic and you need trained providers. And so increasingly, we are really trying to improve the access to high quality education through the International Bowel Ultrasound Group, where we are training doctors and nurses to be able to acquire the skill and the machines so they can bring the technology to you in clinics across Europe. Is it cost effective? It absolutely is. Interestingly, the data to support cost effectiveness and cost utility isn't all that expansive. There's some Italian studies. We have limited studies from the UK. So the very clever docs in the UK have demonstrated an annual benefit of about £500,000 if this is incorporated into clinic. And where does the cost savings come from? There's 3 ways to think about cost savings. Number 1, you avoid colonoscopy, which is very expensive. Number 2, you can potentially avoid MR and CT, also expensive. And number 3, if we monitor you more frequently, then we hopefully will get better disease control, keep you out of the emergency department and in the hospital, and avoid surgeries, all of which are very costly for you as individuals. It's time away from work and school and a productive life, and it also costs the health system. So these are the ways in which we believe it's cost effective. What about implementing this important tool in clinic? Well, this is no small feat, and it actually takes a lot of strategy and a lot of thought and dedication to bring it to a clinic near you. So in the left-hand part of this image, the first step is really raising awareness. So how do we increase the recognition of this tool as a valuable adjunct to care? And it starts with forums like this, that we really have to try to encourage awareness both among providers and the recipients of care, which are you, the patients. If you are aware of an innovation like this, then you are more likely to advocate for it, and then it will be brought to a clinic near you. So I have a very good friend who is a very well-recognized IBD specialist in Canada who works in Toronto, in Ontario, and he had a call from a patient who said, "Dr. Silverberg, why don't you have this in your clinic?" And he said, "I don't know. I will look into it." And what did he do? He looked at all of the evidence and he brought ultrasound and is now providing it to clinic. Now that's a simplified version. The point of this story is, with lots of challenges and lots of effort and work, it was a patient who brought that awareness to Dr. Silverberg, who then did all of what he needed because he knew it would impact patient care. So your voice and awareness is incredibly valuable. Then we have to train doctors from all over the world. And this is a huge initiative that we are undertaking through the International Bowel Ultrasound Group, which is the only recognized certification across the globe. And it will be important to certify doctors who will recruit for clinical trials, as well as provide the innovation in a clinic near you. So this is a very important and very resource intense need, which is education. The other part that's important is the machine. We do need higher end machines. And so this little picture of an ultrasound machine, there are a huge variety of potential ultrasound machines, but those ultrasound machines need to be purchased and then maintained, which is not a small feat. It's altogether possible and less expensive than endoscopy or MR and CT, I will submit, but that's also a part of it. And then physicians need to be remunerated, or providers need to be remunerated, and that structure in many countries does not yet exist. So we have to work towards building the structure for including it into the health system. And that will allow us to ensure that it is available to you in a clinic near you. So not a small number of simple interventions, but a more complex system-wide approach that is necessary for it to be a sustainable resource for you. And again, there is a huge amount of information that we gain from looking at your bowel on ultrasound very important of which in the past, we haven't been able to look at motility, how your gut moves. The bowel, like the heart, is a very active moving organ, and we need to understand how it moves and how it evolves over time, and we can do that with ultrasound. So what does this look like for you? So in your average active patient who needs to start or change a medication, we know that you have activity because you're sick, you're not feeling well, your blood work is abnormal, your stool tests are abnormal. What should we do there? Well, immediately we should do an ultrasound so we can understand the extent and the severity of disease. And I would submit, once we rule out infection, that we don't need a colonoscopy. If you are getting diagnosed for the first time, then you absolutely need tissue and you need an ileocolonoscopy and maybe even a gastroscopy from above. So there are circumstances where at baseline you absolutely need a colonoscopy. But if I know you well, I know you have Crohn's disease, and I know you're sick, and I can get good images on ultrasound, we can avoid a baseline colonoscopy. And then I need to know whether or not the drug is working. So at 3 months, we should look again, and we should do those tests again. We need to find out whether you're symptomatically better. We should do another fecal calprotectin, another set of bloods, and we should do another ultrasound. And there's very good evidence that if you have response at 3 months, the likelihood of having healing at 12 months is much, much greater. Then, depending on how you're doing, we would do another scan at 9 months if you're on a good road, or 6 to 9 months rather. If you're on a good road and you're doing well, then fantastic, we would scan you again at a year. Current guidelines and recommendations suggest that there's still a need for colonoscopy at 12 months, and I adhere to those guidelines. However, I would submit, if all of your tests are normal, you have a normal ultrasound, you have normal blood work, you have a normal fecal cal, that might argue that I don't know that there's a lot of value to add through doing an invasive, expensive test like colonoscopy, and we might be able to reduce or even obviate the need at 1 year if we have all those measures. If it's equivocal or there's a question of more symptoms, then colonoscopy is absolutely warranted at 12 months. And none of this reflects colon cancer screening. That's a whole other topic. And we do not do colon cancer screening with ultrasound. That requires colonoscopy. This is for disease monitoring. So that's a whole separate topic, as you likely know. So again, whether or not you do colonoscopy is up to the provider. I think folks will still lean towards colonoscopy because that's what we know, but we're moving towards replacing colonoscopy with ultrasound and other measures because it's so accurate. In ulcerative colitis, it's exactly the same. This is another consented patient where we've got very active disease. And this is what it looks like on ultrasound, very straight, not folded, and the wall is thickened. So we can look at ultrasound and correlate that with endoscopic disease very well in ulcerative colitis and in Crohn's disease. So I've covered a lot of ground, and we've been talking now for about half an hour. So I just want to summarize for you. What I hope to leave you with are some ideas and some thoughts about how clinical care can change. Now, some of you are in clinics where it's changed and changed a long time ago. For example, in Italy and in Germany, you have led the world in this area. Certainly in Canada, we do nothing but learn from you and how you care for patients. You have been a beacon for innovation across the world. And so as a Canadian, I sit here with a humble ask for you to consider, if you don't have access to ultrasound, think about how it might improve your care. And together we need to advocate for this innovation in clinic that is accurate, repeatable, and tolerable and preferred by patients. It's cost effective, and it can change your outcome. So I think that as a global community in inflammatory bowel disease, this is going to be an innovation that comes to you slowly but surely to improve your care. And I think that there are lots and lots of countries where in the last 5 years, they've gone from no ultrasound to providing ultrasound across the country. And Denmark is an excellent example. So there's lots of places. Canada is another one where we now have ultrasound available for children. And we haven't even talked about children and the importance of ultrasound in kids who can't have endoscopy out of the operating room, and they have to be sedated for MR. Ultrasound is an absolute gift to them. This is what we're looking at across Europe for children and for adults. And there are lots of other really innovative tools that will help us expand and develop ultrasound in this context, such as artificial intelligence. So we have a number of projects where we can use AI to better recognize the thickness of the wall and the characteristics of the mesentery or the surrounding area around the bowel and the motility, so we can better evaluate you with these very clever computer adjuncts. So I want to thank you incredibly for your time. I know that your evening awaits you, and so I will turn it over to the moderator and to the panel. And this is the beautiful mountains in Alberta, and I hope that maybe one day you'll come and visit us in Canada. Thank you very much for your time.
Hi, Dr. Novak. Thank you very much for that. Very informative. And for anybody who has just joined us, if you put the questions in, I will put them to the panel. Professor Novak, just before I invite Roberto to join us, so we have some questions that are now popping up on our screen, but I'll go through them with you.
Wonderful.
If you replace colonoscopy by IUS, that means you can't take an intestinal tissues to make a biopsy?
100% true.
Yeah.
100%
Okay.
true. So at diagnosis,
Yeah.
it's unequivocal that you need a colonoscopy.
Okay.
To get the diagnosis, we need tissue.
Okay. So then back to what you were saying is then your colonoscopies are every 12 months. So IUS works when you're well.
Well, not necessarily. Once you have a diagnosis, so once we have tissue and we know what you have, then from there, we then enter a monitoring strategy. So there are two different things. One is diagnosis, and you need imaging at diagnosis. You need blood work, you need fecal cow, so we get that full picture of you at diagnosis. And then going forward, patients evolve and change and over time. So you're not always the same. Even sometimes in some people, the diagnosis is one ulcerative colitis, for example, at one point, and then later it changes. So it's not that there's no need for colonoscopy going forward, but I think that for sure nobody needs a colonoscopy every 12 months unless you have primary PSC. That increases your risk of colorectal cancer, another topic. But generally, we can replace a lot of colonoscopy with ultrasound once you have a diagnosis.
Okay. Thank you. And then just one other question is, and obviously as part of this talk, we're not promoting any machinery in general, but somebody has asked about the advice on an ultrasound machine in relation to they're trying to borrow it from the radiology department.
So brilliant. And I love to hear this. So I'm so hopeful that radiology will be collaborative and lend you this machine because it's so important. And what is really great, just as an aside, is to be able to collaborate with specialists. So the IBD provider and the radiologist ideally can work together because we can learn a lot from each other. So the ultrasound machines in general are better when there's more computing power to look at the bowel. So there is evidence that handhelds or portable machines can be used, but the resolution isn't as good. So the better the sort of higher end radiology grade machine, the better the images. So it's not easy to look at the bowel because it's a bit finicky. So you need a better machine, but there are some mid-range portable machines from GE, from Samsung, that are beautiful and that are not expensive. So you don't have to, spend hundreds of thousands of dollars on a machine. You can get a mid-range portable machine, but probably the handhelds and the ones that are used often in the emergency department are not going to be quite enough computing power to be adequate on a regular basis, in my opinion.
Okay. I just have one final question, and Roberto, then I'll come to you. After 10 years, somebody's saying there is a risk of colorectal cancer, and the biopsies can obviously tell you if you're going to have cancer. But I think you covered this by saying IUS doesn't take away from any colorectal cancer screening either.
100%, and I think this is just such an important point that we can't mix the two up. Colon cancer screening in patients with inflammatory bowel disease is a whole special area in and of itself, and would probably warrant an entire talk dedicated towards it. What we are using ultrasound for is the detection of disease activity, complications, so things like strictures, abscesses, and gut function, not at all colorectal cancer screening. So that is in the domain of colonoscopy and will remain that, and that is a separate issue. So you've said it so well.
Thank you. So Roberto, as EFCA's patient coordinator and innovation and patient engagement, this must be very exciting for you to see this innovative approach.
I have been pay attention to the presentation. I have a lot of questions, of course, because she has been speaking about preferences, outcomes, therapeutic goal, and I really want to ask, or starting to ask, because sometimes there are several therapeutic goals. For example, right now more than ever, we have histologic healing, transmural healing, we have the mucosa healing. So which one? Are these imaging techniques for everything? There is a case when it's better to use another imaging techniques for a specific therapeutic goal. Are these aligned with the international recommendations?
Yes.
Because sometimes
it's confusing.
Those recommendations are confused from the patient perspective.
Totally. You know what? You've just articulated this so beautifully. We that's just perfectly said. So I would bring us back to the image of the lens. And so when you think about the way we look at anything, we have to think about the view. So depending on the view, it might change the vantage. So you might see something differently from a different angle. And that's how I try to articulate to patients. How we look at you and your disease has to be from different angles so we understand it comprehensively. So that's the first place. Then we think of treatment goals, and the treatment goals that are very clearly established and reflect international guidelines. And those would be conveyed within the STRIDE guidelines, STRIDE 2 guideline, which was published in 2021 and will probably go through another iteration in the next couple of years. And those treatment goals are basically, first and foremost, the earliest treatment target is symptomatic response and then remission. So you need to get better and then feel well. And then the second is biomarkers, because we know that the fecal calprotectin and the CRP respond fairly early. So we like to see those markers go down. And then over the long term, in the first year, the most evidence-based treatment target is endoscopic. But where we come in and what we're questioning is that robust enough? Is that a treatment target that tells us enough about the disease? So you all know probably that sometimes the colonoscopy isn't complete. Sometimes it is, you cannot see into the small bowel, and 80% of Crohn's patients have disease in the small bowel. You can't see it all. So we need another way to make sure we look at you comprehensively. So when we think about cross-sectional imaging, we think about transmural disease, like I showed you with the wall thickening, and that should shrink. So we should see transmural response, so it should get better. And then if it's healed, we know from early evidence that actually transmural healing predicts better than mucosal healing. Now, is it going to replace endoscopy completely? No, I don't think so, because again, we need to look at you in different ways. But it can be, and I think will ultimately be, a very important treatment target that will mix up and do as would be appropriately implemented based on your personal profile of IBD. So transmural response and healing are not a formal treatment target yet. They are not like histology. They are not reflected in STRIDE yet. But my prediction is it's coming, and I'm biased.
Isabella, you're the president of the Romanian Association. I suppose, how do you see this working, or does it work in Romania?
Thank you, Chiara. Thank you, Dr. Novak, first of all, for the invitation, then for the opportunity to participate in this discussion, because I have to admit that the subject seemed interesting for me since I've heard about it. First of all, because I was interested as an old patient that I am from that times when investigation and diagnostic techniques were poorer 30 years ago. So I would say I have now the ability to compare and understand the benefits of the new techniques probably better than many other patients. Yeah. And second, as you say, as a representative of a community of IBD patients of the Romanian Patients Association, we are certainly interested first to understand and then in helping our patients to understand as correctly as possible the role of this type of investigation, to understand if and where it can have benefits. And thank you, Dr. Novak, for the presentation, nice picture and explanations. The first question that arises in my mind is regarding the regulation, particular in each country, the legislation and regulation in each country.
Yep.
I think that these are important
Mhm.
when we talk about IUS, because for the periodic evaluation, for example, based on which we continue to receive treatment, colonoscopy is required.
Yes.
So how can you how do you think about this? Because in my mind, I think that some improvement of these regulations must be done in order to accept the IUS in our periodical evaluations.
It's so well outlined. Thank you so much for that. That's brilliant. And a very good example of how innovation is actually blocked by rules and regulation in different countries. So you try to innovate and improve care, but you are stuck in these rules. So I completely hear you. Advanced therapies are often expensive, and so governments and payers want to make sure that there is very clear evidence of need. So those kinds of rules are based on objective findings. And so what is going to be required, honestly, is more evidence and more widespread adoption so that we can then lobby governments like your government to change those policies so that you have other measures of disease activity which are more patient-centered. So one of the things that governments would be incentivized to change is if the test they're requiring is also expensive. So colonoscopy is just expensive and it's not well tolerated. So we can use lots of different levers with governments, like we want patients to be happy and you have to be patient-centered. And secondly, we don't want to cost the system a huge amount of money by requiring a colonoscopy every year to renew your medicine. And we need evidence for that. And so often in Canada, for sure, we look to the FDA for approvals. And so those things take time and complex submissions. So it would be the same in the Romanian government would look through to the EMA or the European regulators. And these things take time. But I think, honestly, your voice as a patient and this collective body is incredibly important because, of course, you're voters. So, you have power. And I think we underestimate the power that we have to change the rules. Just because there are rules, that doesn't mean that they're updated or they're right. So I think I hear everything you're saying. I'm not saying at all it's easy. And these challenges have to be approached thoughtfully with evidence, but with advocacy as well.
Yes. Actually, talking about advocacy, our plan at the association level would be a bit bigger in the sense that we have already drafted a survey to address patients to find out how much they know about IS, if they have been offered this investigation, if so, in centers in the country so that we can create a general picture
Mhm.
at the country level. And also we are planning other tools like an webinar for patients as part of our patient education and information program,
Mhm.
having a guest, a physician who already is practicing this technique. So as to increase actually the level of understanding and the awareness among patients,
Mhm. Mhm.
providing them explanations from specialists. And only thing I want to add that at the same time we would like to explore also the perspectives of our doctors,
Mhm. Mhm.
our physicians, gastroenterologists, and we even recently addressed the subject with the next president of the Romanian Society for IBD.
Yes.
And we were thinking about establishing an IUS group within this society. At least this
Brilliant.
was his proposal.
This is brilliant.
Doctors would have to be trained, involved in the
Yes.
use of this technique, and
Yes.
be able to train at their turn other doctors.
Yes.
Because we realize actually from what I have understood that this is the learning curve for this is quite a long one, requiring time and dedication. Is that correct? Yeah.
Yeah.
Yes.
And
Everything
I
you
think,
said is brilliant.
and Isabella, I
Okay.
think I'm just going to move on to Vaso there for a second.
Okay. Good. Okay.
Sorry, no. I suppose anybody who's been on an EFCA talk with me before
Perfect.
probably knows I'm not the best time manager, so I want to get through everybody.
Okay.
And
Perfect.
there's still questions coming in. I do have one question, and Professor Novak, I don't know whether you're going to be able to answer it. But if you can't, we will try from an EFCA perspective to get the question. Do you know, is there a list of hospitals that they practice IUS in already? Yeah.
In what country?
I suppose from maybe a European
Oh,
perspective, or is there an IUS group of doctors or physicians?
Yes. So the International Bowel Ultrasound Group is the international organization that is coordinating all of the education, all of the support, a lot of the research, and a lot of the mentorship around education. We could probably get a bit of an idea, and it's quite variable among countries. So, for example, in France, there are a few centers in the north, and there are some growing centers, but it would be very different from, for example, even Norway, like where it's more established in a country like Norway. So there is quite a variability across Europe, Scandinavia, Southern Europe, Western Europe. So, but we could probably get those a bit of a landscape for you.
Okay, thank you for that. I do have another question, but Vaso, I want to go to you first. I suppose from both a Greek association perspective, but also as the youth group coordinator, how I suppose is your view on IUS, with a double hat on, from Greece?
Yes. Thank you, Kira, and thank you, Dr. Novak, for the great presentation. Let me share my personal experience to see a real patient experience on IUS. I'm someone who not only lives with Crohn's disease, but also with Addison's disease. I can personally attest to the unique challenges we face when undergoing routine procedures such as endoscopies. For me, endoscopies can be tricky because Addison's disease can make managing stress during invasive procedures like colonoscopies difficult. The physical toll of fasting and the preparation before the endoscopy can be especially challenging as my body does not produce enough cortisol to cope with this and to handle the added stress. This can lead to complications of my Addison's disease during these type of procedures. And as a result, colonoscopies and endoscopies, even they are vital for monitoring Crohn's disease, come with their own set and challenges for me and my healthcare team also. This is where IUS comes in as a game changer for me, and it was truly offers a relief, a sense of relief. The ability to get an accurate assessment of my disease activity without the need for invasive procedures is invaluable, of course. And it allows me to avoid the extra physical strain that comes with procedures like colonoscopies. And it helps my healthcare team keep a close watch on my condition without adding unnecessary risks to my health. So that was a personal experience from IUS. It's only a personal experience, but maybe there are many people that have also some same or not so same experience from IUS. From the youth group perspective now, you know that young patients are active, they want to study, they want to travel, they want to get a job, and they want to be more free. From a patient perspective now, and as a young patient, the beauty, let's say, of IUS, it offers a non-invasive and quick way to assess the state of our condition. You know, it's very stressful to anticipate another invasive procedure, even if you are young, this will be greater. Having to prepare for it physically and mentally has its own toll on the patient. And also, I think that IUS allows us to get an accurate assessment without the discomfort and all the anxiety that often accompany these tests. And that's really, really important for young patients too. But like any medical technology, IUS is not without its limitations, and it's really vital to discuss and communicate with our healthcare team in order to know that we are properly educated about the benefits and the limitation of IUS before going to do it, or what we want to do after if needed. Now, in Greece, we are very lucky that we have many centers that performs IUS in the day-to-day clinical practice, and also in some children too, not only in adult patients. I think it was a game changer in Greece that we have the opportunity and we have access to IUS. It solves a lot of problems. It gives us better results. And I think that in the future we will be better and better and better. But as we continue, and to conclude, let's say, and as we continue to push for patient-centered solutions and in healthcare, I think that IUS stands here as a reminder that innovation in medicine does not only come with new medications, but also through improving the diagnostic and monitoring processes that make the journeys of people living with IBD more manageable and more, let's say, safe and more well-tolerated, and they give us better solutions in the future. So I think that we are really, really happy and lucky to have IUS. We have to explore it. We have to know its limitations. But I think that the future will be brighter, and IUS will be integrated more and more into day-to-day clinical practice, and many patients, I think, that will benefit from it. That's my opinion and my story. Thank you.
Thank you, Vaso, for that. Professor Novak, I'm just going to ask one quick question, and then I'm going to go around just for a closing statement from everybody, and maybe Professor Novak, I'll leave you till the end to close. Somebody has just asked, what materials or information are needed to support increasing awareness of IUS for the patient community? And that might be an open-ended, very large question. Oh, sorry, Professor Novak, you're on mute.
Oh, I'm so sorry.
No problem.
I might defer to the panelists. Like I do think that it's a complex question, and maybe a to-do or an ask going forward is that we work more closely with you I'm the president-elect for the International Bowel Ultrasound Group, and I would love to just put my hand out to you and say, can we work together in your local environment and connect you to international experts and local experts and work together to answer this brilliant question from Lassie. Like, it's a complex question, and I don't know that I would even start to answer it, because it will take some thought, but it's important. And your voice, I have to say, is imperative.
Okay. And I think just for EFCA members, I will just mention that towards the end, or I'll actually mention it now. Our next step is, I suppose, understanding each of our members, where they are and how people can access IUS. And that we'll begin that as an organisation after ECHO. So just bear with us. Roberto, if I was to ask you for a closing statement, and I'm going to try very hard to keep in time today, but if I could ask you for a closing statement in relation to IUS. Oh, Roberto, you're on mute as well.
Sorry again. No, I was saying that intestinal ultrasound is here. Is maybe the best imaging technique from the patient perspective. However, we need to keep talking and reducing the gap between the several stakeholders, because we still need to generate more evidence so that everybody can feel comfortable using it and accepting it.
Okay, very good. Vaso, from yourself, what would be your, I suppose, closing statements?
I think that together we can make the difference for people living with IBD, and of course IUS has its own place in this field, and I think that all the stakeholders together can make the best for our community and people living with IBD.
And Isabella?
Just a few words. We do need a really good plan for advocating when it comes about the patients. And of course, we do need support for doctors to be prepared, to be trained for this, at least in this part of Europe. So there are two different needs.
Yes, no, and I think, like everything, there is always those needs, and sometimes there is a lot more needs than just two.
Exactly.
Professor Novak, could we ask for your closing statement, I suppose, because maybe some people online, IUS was a new word to them, and it's been a really informative and I think a very good starting point for patients and obviously our members to understand a bit more. But could I ask you, I suppose, to close today's talk?
Sure. And I have to just say thank you so much for the invitation. This has been such a wonderful opportunity, and truly heartfelt feeling that we just love to work with you, and we would love to be able to provide the very best care possible for you. That's what this entire thing is about, is improving your journey and your experience, and helping you to get better with tools that are well tolerated and accurate and easy to use. And I think that there's so many opportunities to make sure that patients across Europe have access to these important tools. And you're at the heart of it. You're the voice, you're the champion, you're the advocate. And we are just here to help you in that journey. So thank you so much for having me.
Okay. I'd like to thank everybody for joining us, and I'm sure we will be in touch with further communication, and hopefully look forward to seeing people on our next EFCA talk as well. But thank you, Roberto, Vaso, Isabella, and Dr. Novak. Have a good evening, a good afternoon to you, Dr. Novak. So have a good day. Thank you, everybody.
Have a wonderful day. Take care. Thank you.
Bye-bye. Bye.